Now moving on to our first section, that is what the types and lesions of the brachial plexus. As I just told you, we will be briefly going through the anatomy of the brachial plexus, where the lesions can occur, how the lesions can occur, and how to identify by their signs and symptoms that what is the level of the lesion. So coming to the brachial plexus, as you know, it's basically a plexus from the cervical T1 nerve root, which is actually arises from the ventral rami of the C5 till T1. If you can see in this diagram, this is C5. It's starting on, and ventral rami are giving off branches to make it initially the trunks. There are superior, middle, and inferior trunks. Then this further gives away branches in form of cords, that is anterior and posterior branches of the trunks form the cord, and they are labeled as lateral, posterior, and medial cord because of their relations to the axillary artery. As these cords further subdivide and they form the final nerve root in form of median, ulnar, and radial nerves. Coming to the pathological anatomy, they can be injured either supraclavicularly or infraclavicularly. For example, due to stab wound somewhere over here above the clavicle, when the scalene muscles are damaged, the brachial plexus exits from the anterior middle scalene muscle. This is where it can get damaged. It can get damaged at the level of the clavicle and results in it's a comminuted high energy fracture of the clavicle. Although this is very rare, but yes, it can occur. The most common injuries are usually infraclavicular, that is below the level of the clavicle. This is where it can get entrapped between the muscles, or usually with the high energy injuries. This can result in infraclavicular lesions. As I just told you, it's formed from the ventral roots of C5 to T1. There's an infraclavicular portion which is actually is the relations to the axillary artery. That is, the lateral cord is lying lateral to the axillary artery, and the medial cord is lying medial to the axillary, where the posterior lies posterior to the axillary artery. Now coming how they can be injured, as I just told you, the injury could be supraclavicular lesions, that is above the level of clavicle. Usually in motorcycle accidents, neck and shoulder are wrenched apart. If, for example, a patient is falling and suddenly tries to catch the hand, what usually results in that the neck goes on the opposite side with the shoulder and is abducted and going to the other side. This can actually cause a supraclavicular type of a nerve injury. Or, for example, a stab wound to the neck can result in the damage to the supraclavicular region of the brachial plexus. Then it is the infraclavicular. This is the most common form of injury that usually results below the level of the clavicle, and this is the most common form because it's where the mostly injuries which take place, usually in case of motor vehicle accidents, in case of stab wounds, gunshot injuries which usually done to the chest. This is where the most of the damage occurs. This is usually associated with fractures of the shoulder and dislocations. There may be a loss of axillary artery as well, may be associated with vascular injuries as well, and there may be other problems as well associated with it. Then fractures of clavicle, although it's very rare, but yes, it can lead to brachial plexus injury, as because infraclavicular part is lying just beneath the clavicle, and usually in a case of a cuminated or maximally displaced fracture of the clavicle, this can damage the trunks of the clavicle, trunks of the brachial plexus. Now, how to identify where is the lesion? Lesions could be preganglionic, postganglionic, or at the level of the trunks, or even in the cords. If it's a preganglionic lesion, that is before the level of dorsal root ganglion, where it's actually exiting from the ventral rami, or actually exiting the C5, C6, C7, C8, and T1 roots. If it's before that, it's termed as preganglionic lesion. It's actually disruption is proximal to the dorsal root ganglion. Usually, that it's not actually a cut, it's actually avulsion injury. It's such a severe trauma. Usually the ventral nerve roots are actually avulsed from the roots. As a result, this is a highly damaging lesion, and it has a very poor prognosis as well because it's not surgically repairable. Now coming to the postganglionic lesion. Postganglionic lesion is that if injury occurs after once the dorsal root ganglion has been traversed by the nerve. Although it is still less severe, but it's still also very high energy, and its prognosis is also less poor compared to the preganglionic nerve injury, but it still has a very poor prognosis compared to the peripheral nerve injuries. It's a rupture nerve distal to the ganglion, and trunk or peripheral nerve rupture actually occurs at this level. Usually surgically repairable, and that is why it has a relatively better prognosis as compared to preganglionic lesion. Now coming to the mild lesion or neuropraxias, in which this could be, according to the CDON classification, neuropraxia was the first form of it, and usually transient loss of nerve function. This could be due to post-surgical hematoma, which may be collection or compression or edema, which may get collected in head and neck surgery, and this can compress the nerve transiently, but usually the nerve function regains it. Nerve regains its function, usually results in a less almost more favorable prognosis as compared to preganglionic and postganglionic lesions. Common due to trivial trauma, recover spontaneously as it's a neuropraxia, and there's mild residual symptoms which may prove nuisance, but usually with aggressive physiotherapy, the symptoms can be covered. Other is the lesions in the continuity. The other form is that whole of the axon or neurotomesis has occurred. This has a better prognosis. Why? Because the nerve has lost its function, but this means that the lesions are continuous. It can be either repaired or nerve grafting can be done. That is why it has a poor prognosis, better prognosis. Now coming to the clinical features. Now clinical features depend whether the upper part is involved, middle part is involved, or lower part is involved. Depending upon which trunk is damaged or which cord is damaged, then it's gonna come up with the symptoms of different symptoms. Usually high energy injuries in case of a high velocity trauma or road traffic accident, it may be associated with gunshot injuries. Maybe low energies are always associated as well, such as stab wounds to chest and neck, but they are very rare. This may result in rupture of the subclavian or axillary artery. As subclavian artery passes the trunks and enters into the cords, there it is actually renamed as axillary artery, and once it traverses the axilla and goes into the upper arm. So actually the whole of the upper limb is actually supplied by the axillary artery. There is associated neurological dysfunction, which is obviously would be present because nerves are injured and muscle would be paralyzed. What we need to determine is actually where is the lesion, that is whether it has C5, C6 or C7 level, or is it a C8 or T1, whether the level is lower or higher, or is it a root avulsion, or is it, if it's a root avulsion, is it preganglionic or postganglionic, is there any associated Horner syndrome or not. That is how we have to assess where is the lesion and what is the type of the lesion, and then we have to manage our plan accordingly and what we need to do about the lesion. As I just told you, whether the level of the lesion and what is the type of the lesion. This is what we have to determine. How to determine the level of the lesion? Usually if it's an upper plexus injury, it would be a C5, C6 injury. The pathophysiology or pathomechanics would be such that the patient had a history of RTA with fall off from the bike in such a way that his arm was pulled in one direction and neck was pulled in another direction. Classically, if you see it over here, the arm is being pulled in this and the neck is going the opposite direction. This usually results in upper plexus injury and sometimes the root avulsions as well, which can be seen in this diagram as C5, C6 nerve root avulsion is taking place. Usually shoulder abductors, external rotators, forearm supinators are paralyzed. There is sensory loss as well. Weak wrist and usually with loss of C5 and C6, there may be a loss of finger flexion as well as the forearm flexion as well. The intrinsic hand may be paralyzed sometimes because if there is an associated C8T1 injury, this may be also associated with that as well. The sensation is lost in ulnar forearm and the hand area. If it is a lower level injury, entire plexus can be damaged. For example, it's more of a severe injury, then it can start all the roots from C5 till T1 may be avulsed. All of the brachial plexus may be involved. Then we need to assess whether it is which compartment is involved, where the sensation is lost. If all the median, ulnar and radial nerve are lost, this means almost all of the brachial plexus is actually lost. We have to identify the site of the lesion where possibly it could be, whether it's supraclavicular at the level of clavicular, infraclavicular. Then we need to preserve usually the dorsal scapular and long thoracic nerve, otherwise this can lead to a winging of scapula. Suprascapular nerve needs to be preserved as well because it's supplying the supraspinatus, because shoulder abduction is done by the supraspinatus. During the first 20 degrees of the shoulder abduction, actually supraspinatus has a role. So if suprascapular nerve is damaged, this can limit the start of the abduction. Therefore, the patient will not be able to abduct his or her shoulder. Now coming to the preganglionic and postganglionic lesion, we need to define if it was an upper root avulsion, then we have to understand whether at what level the root avulsion is, whether it is a C5 to C7 level or it is a C8 to T1 level. Coming to the preganglionic lesions, this usually, if it is before the dorsal root ganglion avulsion, these are irreparable and carry a very poor prognosis. Postganglionic lesions are usually the lacerations which can be could be complete laceration in form of axonectomy, but still they have a better prognosis because they can be at least repaired. It is actually causes could include crushing or burning pain in the anesthetic hand. Hand may be numb. The areas may be first part, the lateral part of the shoulder, arm, and forearm there may be tingling sensation. Paralysis of scapular muscle, the diaphragm, if the upper roots are involved. Actually, association with Horner syndrome can take place, especially at the level from C5 to C7 levels, because this may be present with anhidrosis, meiosis, and ptosis as well. There may be a severe vascular injury, subclavian artery or axillary artery may be involved as well. Associated fractures of cervical spine may be present, so we need to, once we are suspecting root avulsion, we have to see that it could be associated with other multiple injuries as well. Or if these injuries, there is upper arterial compromise, vascular compromise, cervical spine injury, then we should be suspecting root avulsions. Then coming further to how we can test this, there is a test called as histamine test. That is actually histamine which is anti-allergic, is actually given into subcutaneously injected into the skin and usually produces a trip response. There is a flare, there is swelling, there is redness, and there is a wheal formation over the skin, which actually gives us whether histamine test is positive or not. If it is positive, this means that the lesion is preganglionic and there is a preganglionic root avulsion. How we can diagnose whether it's preganglionic or postganglionic, the option include CT myelography, MRI, which is more commonly done nowadays. Unless there is a specific contraindication to MRI, then we can go for CT myelography. And the other option includes nerve conduction studies and electromyographic studies, because they can be done as well, so that we know where the lesion is and whether the muscles have been affected by the lesion or not. Now, briefly going to what is the type of lesion it could be. It could be, depending upon the severity of damage, if you see this diagram, this could be a simple avulsion, which could be preganglionic or postganglionic. This could be a rupture, which is usually complete, resulting in axonectomy. Once the healing occurs, there may be a neuroma formation, which is, although the nerve is not regaining its function, but it's still creating a lot of pain and problems for the patient. Or it could be simply temporary crush, which may be leading to a neuropraxia. As I just told you, it depends whether severity of damage, mechanism of injury, and impact velocity. Mild or neuropraxia could be for grade 1 or 2 Sunderland injury. Severe could be Sunderland grade 4 or 5 injury. Neurotomesis is usually in which although there is loss of nerve function, but at the whole axon sheath is not lost. Therefore, early surgery, that is early intervention in 3 to 6 weeks, can lead to complete recovery of the nerve. In this section, we have briefly gone through the anatomy of the brachial plexus and what are the causes which can damage the brachial plexus. We could be supraclavicular, clavicular, or infraclavicular. Usually the most common are infraclavicular. Then once we get the lesion, we have to decide where is the lesion and what is the type of the lesion. Whether it is above clavicle, at clavicle, or below clavicle, what was the mechanism of injury, and if it is, once we know where is the lesion, then we have to know what type of lesion it was, whether it's root avulsion, it could be preganglionic or postganglionic root avulsion, it could be axonectomy, it could be neurotomesis, it could be simply neuropraxia. Then once we have made the diagnosis that what is the lesion and where is the lesion, then we can proceed for the management. Thank you very much. Keep watching sqadia.com.